a heads up on the satisfaction. Thanks, Matt. Finally, a heads up on the satisfaction survey that will be distributed in the chat towards the end of the webinar. We will drop a line there. Please consider submitting one because it will help us improve. Now, let's see how many people we have. Yeah, maybe we can get started and move into the topic for today's webinar. We will be discussing approaches to evaluate evidence for rare disease guidelines. When it comes to developing guidelines for rare diseases, we are facing the subsequent challenges of a small population, low prevalence, little published evidence. And for a long term now, we have been trying to advocate at European level to develop a methodology for evaluating evidence in rare disease guidelines. This is because, unlike more common diseases, the volume of evidence available to consider for these guidelines is significantly limited, complicating the grading of its strength. In addition, standard approaches may inaccurately classify evidence for rare and complex conditions as weak, leading to guidelines that are not fully addressing the needs of people living with a rare disease. So, how can we optimize all available evidence so that we can have robust guidelines for rare and complex disease? And second, how can we review this systematically? Well, today's webinar is a first attempt of the European Reference Networks stepping forward to answer these questions with the objective to enhance traditional grading approach to optimize real-world data. The webinar is divided into two parts. During the first part, we will share experiences of the challenges in synthesizing high-quality evidence gathered in rare and complex conditions. It will be followed by a Q&A answers of 15 minutes. Then during the second part, speakers will share the approaches taken and potential solutions. It will also be followed by a Q&A of 15 minutes. You can see the full timings in the slides. And we really hope to have a very interactive webinar, so please feel free to jump into the chat in order to make your contributions or raise your hand during the Q&A. We have assembled a panel of experts to share their experiences on this topic today with us. It is my pleasure to introduce our speakers. We have today with us, please forgive me in advance for the pronunciation of some of the names. We have Imran Omar, Vice Chair of the European Association of Urology Guidelines Office Methods Committee, Editor of Cochrane Urology and Senior Research Fellow at the University of Aberdeen. Representing ERN Ernica, we have Iris Den Hel, Project Manager involved in the work package on guideline development with background as a researcher in rehabilitation medicine. We also have Willemijn Irvine, methodologist and researcher, experienced in the field of rare pediatric diseases and congenital anomalies. From ERN Genturis, let's welcome Manon Angels, project manager involved in guideline development and processes, and Tom Kenny, GP and public health physician, contributor to several clinical guidelines for ultra-rare diseases. Finally, from ERN Ithaca, it's my pleasure to introduce Agnes van Eigen, intellectual disability physician from Amsterdam, expert of rare genetic syndromes and chair of ERN Ithaca Guideline Working Group, and also Charlotte Vasterland, guideline methodologist for the Dutch Federation of Medical Specialists, the Amsterdam University Medical Center, and the ERN Ithaca, with background in research on trial methodology for rare diseases. Finally, we also have Matt Bolt-Jolson from EURORDIS, who will be moderating the Q&A sessions. And welcome, everyone. Matt, I pass the floor on to you. Thank you all, and let's get this webinar running.
Thanks a lot, Nora. And I think we're starting now just going to focus on some of the challenges which we're experiencing in synthesizing high quality data for rare and complex conditions. We've got four short presentations. So we have Imran, who will do a first one, and hopefully we can build the conversation around these challenges and experiences which we have from different perspectives. So I hand over to Imran. Can you stop sharing, Nora? Thank you.
Yeah. Thanks, Nora. Thanks for your kind introduction, and thanks, Matt and EURORDIS, for inviting me to this webinar to share the views of the EAU and my experience. So I'll start sharing my screen. So I hope you can see my screen, my slides.
Yes,
Okay.
we can see that.
So I have no conflict of interest for this presentation. So as far as EAU is concerned, we try and base our evidence on the highest level possible. And we try and do systematic review of randomized controlled trial. But as you know, it's not always possible. Randomized controlled trials are not available on all the topics. And especially when it comes to rare diseases, we have to rely on lower level of evidence. For example, when we are talking about like penile cancer or some other rarer condition in which there are no RCTs or prospective data, we have to rely on low-level evidence like case series, case report. And sometimes, like there is no evidence. So within the EAU guidelines office, we have to still make some recommendation. We can't say to the healthcare professionals that because there is no evidence, we can't make recommendation. We still have to make some recommendation. So these are the challenges that we normally face, but I'll quickly summarize the process, moving on to the challenges. So for most of our recommendation, we follow the traditional systematic review process. I'm not going to detail, but this is a graphical representation how we start with the research question and how we make the final guideline recommendation. And there are certain stages in between. If there is interest, then obviously I can elaborate it further during Q&A question. And when there is evidence available, we try and follow the grade approach. We try and follow the grade approach and make the guideline recommendation. So the recommendation could be of high quality. It can be a strong recommendation. And when the evidence is of low quality, it could be a weak recommendation, but still a recommendation. Now, as you know, the scope of the EAU guidelines is very wide. So when it comes to like oncology, we talk about all the various oncological conditions. We have guidelines recommendations for various oncological conditions, but then obviously we are also covering the non-oncology topic like male LURS, female LURS, urolithiasis, neurourology, renal transplantation. So you can understand that the scope is so wide that it's a common problem that the evidence is either of low quality or is absent. So these are the typical challenges: low level evidence, typically coming from single case series or case report, or conflicting evidence. So sometimes, like there is very little evidence and, like whatever evidence we are getting, it's all conflicting. So one small study is saying one thing, the other is saying another thing. And then obviously we have to come to a conclusion to make some recommendation. And then there is no evidence. So, like hardly there is anything available, but still we have to make some recommendations. So these are the typical challenges that we face within the EAU guidelines office. So I'll stop over here before moving on to the solution and whatever plan we have made, how to tackle with it. So yeah, and I'll stop sharing my screen.
Thanks, Imran. Perfect timing and a summary of some of the challenges which we face in rare diseases. I think just building on that, I think we can go to Iris and Willemijn, who can share and maybe add to what Imran's saying or contradict what he's saying. Maybe you think there's lots of high quality evidence out there.
Thank you very much, Matt. We also like to thank you and Nora for the invitation to share our experiences on behalf of Urnica in developing guidelines and the challenges. So Urnica has developed several guidelines over the past year with the help of Qualicura. And Urnica experiences a few challenges, being the availability of little evidence, the heterogeneity of data, and the challenges regarding question type. So these three, we will explain to you how these challenges look by giving examples of Urnica developed guidelines.
Yeah, so as you heard in the previous presentation, little evidence is a problem that we face. I think that this not only has to do with little available papers, but also with the study type. So ideally we want prospective studies, but in practice we mostly have retrospective experience type observational studies. The common title that we find a lot when reviewing for one of the rare disease guidelines is Disease X, a 20-year experience. So you can imagine that in these type of studies, there's very little clear connection between an intervention and an outcome. And this is the type of information that we need to do an evidence-based guideline evaluation. So just some examples from recent projects that we did within Urnica. We are currently working on a guideline on Valosil, which is a rare congenital abdominal wall defect. We have placed an assignment with the librarian for a search, and only on the topic on Valosil, you get 700 studies, and many are case reports, and we found less than 10 trials, which are not even randomized. And then, for example, we recently did a consensus statement on pediatric achalasia, and there we found 789 studies and only 2 trials. So this is, I think, a good example of our daily struggle with the evidence base that we have to deal with. Second is the heterogeneity of data. So you see the pictogram, we cannot compare apples and pears, and still this is what we have to do. So we find the heterogeneity mainly in the outcome measures, but also in the time measurement points and the study population. Some examples that we have is that for the gastroschisis guideline, we looked for outcomes of neurodevelopment, and we find a variety of different measurement scales measured in different points in time. So one, for example, measures the neurodevelopment at 18 months old, and the other one at school age, so very long follow-up. Outcomes that are very difficult to pool and compare. So for the guideline on necrotizing enterocolitis, we found that one of the biggest issues with the studies was that the study population is including also other patients with a different diagnosis and a different reason for the perforation of the intestine. And this other patient group that is also often included is much less dreadful. So the outcomes of this study are less reliable because of this mix in patients. And this is, of course, done to fill up the studies because there's too little patients with this rare severe disease. And in the pediatric achalasia, we found that it's very difficult to make conclusions based on the studies because the age range in some of the studies is very wide, and pediatric achalasia is something that can happen between 0 and 18 years old. So you need a wide population, but it would be more helpful for the conclusions if you have a pool of older children, let's say teenagers, and a pool of very small children between 0 and 3 years old. And this is what we didn't find and what made it hard for us to make any conclusions. Second one is a question type. So I chose this picture because it shows that you want to ship a parcel, but it doesn't fit in the box. And this is what we have quite often with the questions. So if we do analysis in the beginning and we ask clinicians, like, what are the questions that you want to address with this guideline? Then there's also often in the rare diseases that are so complex, also questions that are not typically a PICO framework, so not comparing an intervention or not really prognostic, but more, for example, based on what diagnostic workup should we do without wanting to look at the individual evidence for each test. So short example also, this is mainly questions regarding the diagnostic workup and the long-term follow-up. So how can we make the recommendations to these questions evidence-based still remains a question for us. Thank you.
Thanks, Willemijn and Iris. It feels like one of the common messages is around the level of evidence which we have in rare diseases. I know we'll come to solutions in a minute, but the question for me would be around looking whether the issue is the evidence or whether the issue is the tool to grade the evidence, but maybe we can come to that in the Q&A. I think we're going to move to Manon and to Tom, if you're free. Could you stop sharing?
Oh, sorry.
Thank you.
We've experienced a number of issues as we tackled a range of guidelines. And it boils down to, in rare diseases, almost any guideline suffers from a limited number of articles. This comes from a number of factors. We have relatively small populations affected. Those small populations only ever see a smaller number of centres, of which only a few of those centres see enough patients to create solid experience and evidence from that. And out of that comes a vanishingly smaller number of researchers. This means when we're considering evidence to grade standard, the evidence is skewed, as has been said in the previous two presentations, towards the lower levels of evidence. It's a real challenge to connect these types of evidence to the experience of the rare disease community. What we're searching for is the best available evidence, rather than aspiring to a quality of evidence that is unachievable given the tiny populations of people affected. There's also an issue with the concept of lower levels of evidence, when what we are searching for is absolutely that best available evidence. Calling them lower levels is an impediment to creating what can be enormously important and high quality guidelines to guide the practice of clinicians. Guidelines for more prevalent conditions with less complexity are almost always seeking a point estimate of the effect to make their decisions. And one of the challenges we face in rare and complex diseases is that is nearly almost always impossible. What we end up looking for is directionality. That directionality is by far the more important thing, and far more important than a point estimate of effect. When we're looking at a set of potentially relevant papers, it's in the low 10s or maybe 50 papers. The loss of any single article that gives some indication of directionality, getting excluded because of a perceived low level of evidence, that can be a critical loss to the potential information and creates a huge challenge when you are trying, as the other speakers have talked about, to help people make decisions and guide clinical practice. Because when you're faced with a patient, you need to make a decision, you need to do something. Even a decision not to do something is still a decision. And we feel that burden is a huge challenge in drawing from the available evidence and putting that into a guideline.
I think last but not least, before we go to Q&A, I think we've got Agnes and Charlotte.
Yes, thank you. I'll do part one, and I'm the one who came with the problems, and Charlotte came with the solutions. So I'm the chair of the guideline working group of ERN Ithaca, European Reference Network Ithaca. Next slide, we can show you it's about rare genetic and neurodevelopmental disorders and congenital anomalies. And it's more than 2,000 disorders are involved, and that's for the diagnosed people. And of course, there are many, many undiagnosed individuals with intellectual disability and congenital anomalies, because these are genetic syndromes which implicate their multiple organ systems are affected. Lots of these disorders are also addressed by other ERNs, so that's why it's especially nice to be together today. So I'm a clinician as well as, well, I'm not a guideline methodologist, but interested in guidelines because it's a way to have impact in the consultation room, because you may all recognize the problem that our patients are frustrated by, that they come with their child or their adults with a rare genetic disorder, and a very important question, for instance, on neuropsychiatric problems. and either the clinician says, oh, I have no idea, so don't come to me, I can't help you, or maybe they overtreat because they're just so afraid to miss anything that everything is addressed at the same time, which can also be very complicated. And it's very frustrating, of course, for parents as experts as well to feel that their problems and their expertise is not addressed properly. So as a guideline working group, we have project managers. We have Charlotte as a guideline methodologist and also a very talented PhD. And now we have sort of developed a framework that we want to deliver a guideline which is published, a scientific guideline, but of course more in lay language as well. We want a summary, a screening summary for clinicians to really access very easily. And we also are developing parents versions because they're usually the carrier of the expertise. So those are our deliverables. The challenges we want to address today are the rare conditions, but also the shared comorbidity, which are not addressed by the guideline for just a genetic diagnosis. And despite our lots of efforts over the last couple of years, we only got 5 guidelines completed because it's just very laborious to do this. And of course, we won't be able to address our whole population just addressing rare genetic disorders only. So that's why we also decided to go for the comorbidity that is shared. We are addressing transition of care, challenging behavior. But of course, for those guidelines, we need many, many multidisciplinary experts, which are sometimes quite hard to find on a European level. So we have quite a challenge. How do we prioritize which ones to choose? If there's so many disorders, which methodology do we use? How can we endorse existing guidelines? Because if there are really nice guidelines existing, why we don't want to do double the efforts? Of course, there are some narrative guidelines which don't do systematic reviews, which would be nice to endorse, but of course we may miss evidence as well if we don't do the systematic searches. So those are questions we really run into, for example, recently with Fragile X syndrome, when there are about 5 national protocols, which are quite narrative, but really nice. And it would be so nice to adopt one of them, but which one? And if we adopt one, then it's really a difficult decision. If there's no evidence, how do we gather knowledge from, of course, parents, from caregivers, from experts in a very systematic, transparent, but also fast way? Also, of course, tested knowledge is very interesting to gather the expertise from parents, which is not always so explicit. And how do we incorporate the patient values and, of course, the intercultural different scenarios? Which scenario do you do, the utopic scenario of care, or do you formulate your recommendations, or like the minimal care? So those are the questions we run into today. And then, of course, the implementation. How do we implement? How can we create national collaborations with between the ERNs and national guideline organizations, for example? And what's the legal status of these guidelines if they're used? So these are just a summary of the things we run into, and then I'm really interested, of course, in the next session when you guys will address all the solutions.
Brilliant. Thank you very much, Agnes. Is there any questions from the floor from what we've heard so far? If maybe someone can raise their hand. I can see Paul put a comment in the chat. Whilst people are going to raise questions from the participants, I just wanted to come back with just so I can see everyone. That's better. I've heard a lot about low quality or low level of evidence, and is a hallmark of rare conditions, because. So my question is really the challenge, the issue, the evidence, or is it actually the tool in which we use to grade the quality of the evidence? Because if you're looking at a condition which is a prevalence of 1 in a million, you'll never have a big patient population. So the publication probably is covering proportionately actually a large group of people compared with the affected people globally. So is the issue around grade, or does grade still work? I know that maybe Wilhelmine, you picked up a point about there's ways around this, but I'm just wondering what the real challenge is. Is it that the evidence is weak, or is it actually we're looking at it in the wrong way?
Well, I think it's actually both. So that the evidence is weak, that is a part of the problem, but the bigger problem is to apply a method like grade. You need to be able to pool all the evidence. So you evaluate the certainty of the evidence on the level of one single outcome. And if you have so many different outcomes that are researched and evaluated, then you will never be able to make a pool. While with more similar outcomes, this could be possible, and this could lead to more sure conclusions. So I would say it's not really one or the other, but the factors are intertwined.
I can see a hand raised by Simon. Maybe you want to come in, Simon?
Hi there. Yeah, thanks so much. Just a couple of comments, one negative and one positive. Let's finish on the positive. The negative is, sadly, it is not just rare diseases where there's lots of really poor quality trials. I'm not sure that helps us in the rare disease space, but sadly, the reality is that even in more common situations, there's lots of poor quality trials. However, to make a slightly more positive point, I think this grade thing is too simplistic. I think if I have a single arm uncontrolled study, that kind of comes low down the grade criteria as opposed to a randomized double-blind study. But it depends a bit on what you're measuring. I mean, if I'm measuring fluctuating symptoms, patient reported, then a single arm uncontrolled study is pretty low grade stuff. But if I have a patient with severe symptoms and I treat them, and very quickly there's a substantial change in their behavior and their outcome, that's actually pretty convincing. So both of those are single uncontrolled studies, but one would be really convincing and one would be really unconvincing. So I think using this grade system, it needs the context thought about a bit.
Does anyone have any comments? Imran? Thank you, Simon.
No, I agree. I mean, what Simon and Wilhelmine have said. One thing which I want to highlight, like the challenges of the rare disease, and like as Matt, you said, like if the disease is like 1 in a million or 1 in like 10 million, we are never going to have an RCT, and we are never going to have a big cohort. So I think one probable solution could be real world evidence. So whatever evidence is there, and that's the area which is evolving, big data, AI, and if we can combine data from multiple centers using real world evidence can help us to some extent, but the challenges will remain, and at least for the near future, because this is an evolving science, it's developing. At the moment we are applying it to, again, common condition. We are not able to apply it to rare conditions. So that's what I would like to say. I mean, there is some hope for the future. Things can be improved in future as far as evidence synthesis is concerned.
Thanks, Imran. I think Charlotte wanted to come in, and then Agnes.
Yes, thank you. Yes, I think I am in agreement. And from our perspective, I think the grade methodology is not even the largest problem. I would be willing to just assume, when there are such small amounts of literature available, that there will be a very low grade score anyway. But the challenge is, how do we then provide recommendations still that we can really help the clinical field with? I think that's really our next challenge. Even if we have a very low grade score, that's fine, but can we still formulate recommendations that go towards a certain direction? And if yes, how do we do that?
Brilliant.
Yeah. And if
Thank
I
you.
could comment on that, As with an example, for instance, in some genetic disorders, especially if pharmaceutical companies are interested, there may be some very weak evidence or no evidence for an intervention, but at least it's published, while the routine usual care is never published and probably much more effective. So you get evidence for very weakly supported interventions, and that causes a lot of confusions with clinicians who Google, of course, and then they still prescribe it because there's the one with at least some evidence for it. So that's very confusing. So I do think what Charlotte says, we really need a way to get the care as usual really into the guidelines as well. And we run into problems because the clinicians are quite difficult to involve, especially internationally, because those are not the ones who are usually involved in the ERA and Ithaca, because they're more diagnostically interested and not the clinicians. So that's, yeah, some addition.
Thanks, Agnes. One of the reasons why we wanted to do this webinar was, you know, if we look at therapeutic development, when it comes to orphan medicines, there is a different type of sort of evaluation of the effectiveness of a therapy going through EMA, etc. And we're very comfortable at a national level, let's say in the UK, in NICE, to not think about quality of life for the level of resources. When it comes to ultra rare conditions or rare conditions, we think in a different way, or we have to think in a different way. So my bugbear, as it were, is that when it comes to therapies being approved, we use a different approach to evaluate the effectiveness of the therapies, and it can be very small set of data, you know, for some of the genes therapies which are there. But when we come to guideline development, which, you know, as you said, Agnes, actually there's a lot of probably routine care out there with very strong evidence which never really gets published on. So how are we not shooting ourselves in the foot by not trying to think about a different way to approach this, and not be too fearful of, you know, stepping a bit beyond grade, as it were. I did used to say an modified grade approach, but maybe it's better to say an enhanced grade approach. So I know we'll be talking of some solutions in a minute, but I don't know whether any of the panel want to add to that. Are my frustrations yours or Willemijn?
Yes, but I do really understand you. I also think is that one of the difficulties is that even if you decide to use a grade system, that grade is more than evidence alone. So it's always evidence combined with the opinion of experts, experience of patients. But how do you evolve all those things besides the evidence in a structured way without falling into the pitfall of sitting with each other in a room and having the person that has the loudest voice has the hardest say. And I think that is maybe even more of a challenge in how do we, in rare disease guidelines, balance the use of evidence and of evidence-based methods with the experience of experts, where there is so much value in their experiences. This may in the rare disease even be of higher value than the written evidence. But how can we include that in a structured way? I think that is the challenge that we're facing.
Great. Thank you, Willemijn. Imran.
Yeah, Willemijn has partly covered what I was trying to say, but just want to add that, you know, like grade works very well when there is evidence available, but we are dealing over here where there is lack of evidence, no evidence, or conflicting evidence. So, you know, like there are some potential solutions which I'll be presenting in the next part, but, you know, like grade is a wonderful system, but only works when the evidence is there. When there is lack of evidence, there are alternates, and that should be explored.
If I may add to that,
yeah.
I think then the definition of evidence is again important, because now we're talking of published evidence, while evidence in the clinic is also evidence. So it's then again combining the evidence published and the evidence in the clinic.
Definitely, and that's where we have to use real world evidence. So electronic health record and all those things, they play a major role in the evidence synthesis. Fully agree.
I think the two bits may be going through my mind, and maybe is there any other questions from the floor? You want to raise your hand, but whilst you're thinking of your question, I can see that some of you are, like Olivia. We have that hierarchy of quality evidence, but when we look at I've read some publications or articles that actually, the research using double-blind clinical trials, those, the research design of trials isn't perfect. So actually, we have this hierarchy of what is higher level of evidence, but actually, there is some thinking around like N of 1 type approach is a different way to approach looking at the effectiveness of interventions and doing research. So I think grade's very good in one way, but it's not necessarily a perfect solution, because the way that research is conducted has had some critics. And the other bit for me around the grade process, that step about doing the systematic review, making that step from the evidence to a decision, it does require a level of judgment, does require those experts in the room to discuss those the merits of that. And it's never, as you say, Willemijn, the package doesn't always fit the box. So you have your evidence come up in that step from evidence to decision, can be quite a big step. So actually we are already in the grade process relying on gathering clinical consensus, but maybe the methodology isn't quite there. And maybe for us in rare diseases, that discussion is a bigger discussion, because actually the real world evidence out there from the clinics, as we said, could be better harnessed in that process. I think Charlotte, and then my colleague Ines.
Yes, thank you. And thank you, Matt. I think you really verbalize our main issues. Also, the design of the N of 1 design, I think, is very interesting. Also, to maybe develop a bit further how a grade methodology would evaluate that. But aside from all of that, I think what we are really looking for as well is just some practical help. How do we decide how to tackle these issues? When do we decide to go for a consensus statement instead of a full guideline? How do we actually evaluate registered data instead of randomized trials? Should we describe all of the case studies that we find, or is that just too much work with little outcomes? I think really practical tools like that will really help us in our work. And I really believe that if we jointly tackle these, we may improve really our clinical guidelines in the future.
What occurred to me when you were talking was I did a summary of the different levels of evidence we have in grade, and I did it as like a pyramid. And at the top, level 1 was the best, and double-blind randomized trials, meta-analysis, etc. And at the bottom, expert consensus. And I feel for rare diseases, we need to flip that pyramid on its head. Actually, at the top should be expert consensus. Because of the heterogeneity of the conditions, because of that real world evidence out there, we have to harness that. Because of the challenges we'll never get, as Tom highlighted, though very few patient population, there's even less expert centers which have enough patient populations to produce that enough to do research. So I think we have to turn the approach a bit on its head.
That would be revolutionary. I really
like
that idea.
I like the idea of flipping grade on its head. I think a bit more. Ines, you're on mute. Oh,
sorry about that. So my question to you, Charlotte, and others here that are working in the ERNs is whether you've been revolutionary enough to try out and actually use real world evidence in either when you were developing consensus statements or clinical practice guidelines. I don't care if it was one or the other, because the thing that I can think about different levels of quality in those electronic health records, depending on the center, depending on the country, and depending on lots of other things. So I was wondering if there has been any experience around that, actually, tapping into that data. And if not, whether you plan to do it in the next 3 years, if that's kind of if it's been somehow considered in your grants. Thanks.
Willemijn, are you coming in to answer that? Yeah, super.
Yeah, so good question. We have not done it yet, but we are at the moment planning a pilot in which we will include data from the Urnica registry. As this data, we've thought a lot about how can we involve this data, because there has not been data verification yet, so we are unsure of how reliable this data is, but that is why we are using an observation system. So we are presenting aggregated data on certain issues to the panel, and we're asking them to rate their perceiving of the effectiveness or of the extent of an effect. So this is, yeah, we're doing this project in the coming year.
Thank you, Willemijn. I'm just checking out the chat, and Charlotte, you wanted to add?
Yes, just very shortly, we are trying to involve really the patient view as well as extra data in the methodology type of doing focus groups or extra interviews, just to make sure that that data is involved as well. Just to add to the to that extra bit of information in the evidence to decision framework.
You sound like you should one of the ERN team at EURORDIS. That's great to hear the patient voice being included as for that. We have a couple of comments in the chat. I think Paul highlighted around, should we not in the guideline really include a paragraph about the population size, in which case to highlight the statistically robustness of this in comparison with the total size of population. I think that's a good suggestion, Paul. And we have from Carmen, she highlights about one of the challenges really is about the reporting of outcomes, which I think Willemijn, you highlighted that there was inconsistency around that, and whether we should encourage people to use the checklist like CARE guidelines. And then from Stephanie in Sweden, the HTA agency is arguing strongly for mainly using RTCs. Can we argue against this from a rare disease perspective? I think when it comes to rare diseases, if it's in therapeutic development, lots of people don't, use a different type of methodology for health technology appraisal for orphan medicine. So I think that's an easy one to argue. Tom?
So we do have to remember the HTA question is a different question. If we're talking about guidelines for clinicians to use in clinical practice, that is different than HTA bodies wanting to make reimbursement decisions about medicines based on whatever levels of evidence. I agree they should be using wider evidence, particularly in extremely rare and complex conditions. And this insistence on only using RCTs is actually a form of discrimination. It's a form of rationing that is directed against rare diseases. I guess they have the right to do that, but I think we should challenge it, but we can't challenge it on the same basis that we're challenging only using RCTs within clinical guidelines.
Brilliant. Thanks, Tom. So I think that was a healthy discussion on some of the challenges. I think the format works for me, and we're going to repeat the format on some of the solutions. So I think we wanted to end the webinar by actually being a bit inspired about how we can overcome these challenges to have robust, effective guidelines. So I think we start off, with... So I think the first people, double act, as it were, I'd like to invite Willemijn and Iris to highlight some of the solutions.
So for this part, Willemijn and I went back and we thought what was interesting on our experience and possible solutions for you to know. So some of them are trial and error, and some of them are actually things we use in practice now in our guideline groups. And the actual solutions are still to be found, of course, which is also why this webinar is here. But we now will give a few examples based on the three topics we discussed in the previous presentation. So on the availability of little evidence, on the heterogeneity of study data, and on the challenges regarding question type, if it works well.
Yeah, sorry, I was, yeah, this is the one.
So on these three topics.
Yeah. So this is again the three topics. And first of all, how do we overcome little evidence available? Well, I don't think we can really overcome it, but this is how we have been dealing with it. So one of the things that we've noticed that in a lot of articles for rare diseases, the authors tend to pool multiple stages of the treatment process into one article. So for example, if you're looking for an article on cardiac disease, then you get really specific on one intervention for atrial fibrillation, for example. But the rare diseases are much more often a longer process of treatment and care is described. And the keywords in an article are not so specific that if you are making a search strategy per PICO question or per topic, that you're finding everything. So we stopped searching per PICO, and we are doing now an overarching literature search only on the term of the disease. This helps us to identify more articles and not miss anything because the keywords are not found. Second thing is that we find really important is we gather information on clinical experience in the guideline panel. So this is expert opinion, but it could also make a shift maybe towards expert evidence. So we really want to ask clinicians about the cases that they have seen and to visualize where on a spectrum between benefit and harm they would score that. The third thing that we do and that helps us sometimes is use stronger evidence that is available for less rare diseases that are similar or have similar aspects. For example, in the congenital anomalies, we have a lot of diseases where the patients receive one or more surgeries when they are still very young babies. And we didn't have any evidence on the longer term effects of multiple surgeries in these children, but we do have that from premature babies and the relationship with intubation and general anesthesia, for example. So then we can also go out on a limb sometimes and look into other aspects of the disease or other patient groups. So secondly, we have the heterogeneity. So to make it a little bit easier for us to make a synthesis of the evidence that we find, is that we make clear work definitions at the beginning of the process. So in some projects, we have seen that clinicians then come together and talk about an issue, and they have different definitions of that issue. And then sometimes it's not feasible to say, well, oh, this is the new definition for all of you. But then we just pick one definition for the sake of the analysis and we stick to that. And that helps to make it a little bit more structured throughout the process. And the second thing that we do is that we hardly ever make a meta-analysis, so as is recommended in the grade system, but we pick the most relevant outcomes and we analyze per outcome. And sometimes that means that we make 4 or 5 separate analyses on 1 or 2 studies each that go on neurodevelopment, for example, and then we ask the panel in the end to score their judgment over that summary. So how do we ask the panel to do that? Usually we, even if we don't have a lot of evidence, we use the evidence to decision framework from GRADE, because I think it's a very good structure for discussion, and it really helps to separate the main road from the side paths, so to say. And we have usually, to discuss this evidence to decision framework, a big face-to-face meeting where we meet for 1 or 2 days with the panel. And before that, all of them fill out a survey, and they read the summary of the evidence, and then they judge their overall impression on the outcome, on the different outcome measures. And then in the live meeting, we can discuss all of that. Number 3 is the question type. What we do is that we use all the available evidence that we can find to inform the guideline panel. And then usually this is a problem for us when there are questions about follow-up or diagnostic pathways, or what kind of testing to do after a baby is born with a certain condition. This can be observational studies on the different types of diagnostic things that are to do, for example, an MRI or an X-ray. And then we reach a recommendation or reach agreement on a recommendation with a modified Delphi study. Thank you for this.
Thank you very much, Willemijn, for really clear answers. We'll come back in the questions and answers really to explore that bit around that evidence to decision, and you know how that can be more beefed up, as it were, for rare diseases, because there's such a different, a bigger range of different types of evidence there to draw on. So we'll come back to that. I think the next one we were going to ask Manon to Tom.
Let me share my screen.
Thank you very much.
So, okay, so you can all see my screen. Yes. Oh no.
Not yet.
No, I get error messages that Zoom will be closing.
Shall I share?
Yes, please.
Oh. So here you go.
Yes.
I think we're here. Okay. Have I lost you, Manon? I think you might be muted. I think she's frozen, actually. Maybe we jumped then from Manon to Charlotte and Agnes. Is that okay? And then we come back to Manon.
Seems sensible.
I will share our slides again.
The joys of technology.
Yes, so as a warning in advance, I do believe we still have more problems than solutions, but as a first step towards solving all our challenges, we would like to present 3 solutions that we have been working on in the last couple of years. One of our big issues in the Ithaca context is the setting of the priority setting. We have so many diseases and of course little time and resources. So how do we come to the decision of which topics to do a guideline for? So we are currently in a process of making a list of criteria to prioritize. We are doing this in a Delphi study so that we eventually have a list of criteria that we may base our prioritization on. And then as a next step, we can actually do this prioritization based on this very well thought out list of criteria. And maybe this is something that other ERNs may use as well. Although our criteria are probably mainly for our specific population, but still they may be relevant also to other ERNs possibly. One of the other solutions that we are working on is something that Agnes already mentioned. Yes, there we are. Is that we do a transdiagnostic approach. So we don't only make guidelines for specific syndromes, but we make guidelines also for issues that a large group within our population may have to deal with, such as PIMD or challenging behavior, transition of care, and also sleep. I think this is really a good solution to really help a larger population with a guideline, although these specific guideline projects really come with their own methodological challenges as well. So this is something we haven't really perfected yet, but it's something that we are currently devising. And then one other solution that we are currently working on is to really make more information on how to do this evidence to decision. How can we really involve the patient preference in this evidence to decision framework all the time? So what we are currently doing is gathering values that are important to the patients, families, carers in our population, and make a standard list of values that we try to answer within our evidence to decision framework in all of our guidelines, so that we make it a bit more standardized that these values are important and also involved in our recommendations. So as I already mentioned, we still have more issues and solutions, but I think our prioritization problem will be improved in the next couple of years, and also how to involve the patients, I think will be improved a bit further. But still, there's many topics to be discussed, and I really hope that within this group of, I think, talented methodologists, we may be able to improve these. So I really hope that we can collaborate on this level, and maybe we can add an agree or grade module for rare diseases specifically, or make a decision framework on how to choose for consensus statements instead of clinical practice guidelines, how to really do the prioritization properly, how to deal with conflicts of interest, how to deal with a proper implementation, and also how can we make a decision on national documents that exist? Do we endorse them? And if yes, based on what type of criteria? And I think if we collaborate on these issues, very practical issues, many of them, we may be able to really, in the near future, improve our work.
Thanks, Charlotte. Just to underline what Agnes highlighted at the beginning, your patient population is those ultra rare indications where, a lot of other networks have, over the first 5 years, have endorsed lots of guidelines, but that was because actually there were bigger patient populations. So, each of the ERNs is different. Epicare again is very low, very rare conditions, and there's not going to be a huge amount of existing research and publications, and therefore there's not lots of guidelines already there off the shelf to be endorsed. So your challenges are quite unique to a few of the networks, and I think some of the solutions you highlighted is really good. And I love the fact that you highlight about the point around patient preference in that decision to evidence to decision framework, and I think that's really important to underline. I think Manon, you're back.
Yes, I am. So sorry for the technical failure.
It's fine. I will share the slide for you. And
perfect. Thank you, Matt. Yes, perfect. Thank you. So within ERN Genturus, we have developed now 4 4 Genturis guidelines that were published and 2 were just submitted. And we all did this based on our Genturis guideline development policy due to
I thought the internet was bad in Germany. I think the Netherlands is giving you a run for its money.
I don't know.
We lost you. You're back.
Yeah, it was just kicked out. Let me try to close my working environment. Maybe that's occupying a lot of bandwidth as you are sharing the slides now. So what I was saying is that we indeed developed a development policy regarding guidelines due to the challenges that exist, and that we indeed could not adopt GRADE for our very rare Genturis diseases. So this methodology was based on internationalized recognized methodology for guideline development, but we adapted it to be applicable for rare diseases as well. Matt, can you go to the next slide? So I will present 3 important steps regarding evidence synthesis and evidence grading. And the first step within our policy is that we'll do an extensive literature review done systematically. So not a systematic review, not with PICO questions, because indeed we cannot really develop those PICO questions, but we do more broad search on the Genturis syndrome and then extensively review the literature that is published. And in that way, we will be able to answer the clinical questions and formulate draft recommendations. Matt, can you go to the next slide? So when we have those draft recommendations, we will check consensus on those draft recommendations, and this will be based on the experience and knowledge of a lot of clinicians and patient representatives. So within Genturis, we work with a core group who will actually write the guideline. We have an extended group in which the core group indicated other experts on the topic, but we will also ask within our network if there are experts on the disease, and if there's overlapping topics with other ERNs or other organizations, including patients organizations, we will ask them to also submit their experts so they can contribute to the guideline as well. And to check that consensus, we will use a modified Delphi approach, and we will use multiple survey rounds. So Matt, if you can go to the next slide. So the third step is then we have draft recommendation finalized with a consensus, and we do not grade the evidence, but we grade the recommendation to balance the weight of both published evidence and quantify the wealth and of expert experience and knowledge. And you can actually see the strength that we use within our guidelines in the table below. So it's really a combination of expert consensus and the consistency of evidence, which includes the published evidence as well as the opinion. Then my next slide is again just a summary of the 3 steps regarding the evidence within our guideline development policy. So within Genturis, we use an extensive literature review done systematically. We check consensus on the draft recommendations, and then we use the Genturis grading of the recommendations. So that's it in a nutshell, and I look forward to the discussion and the Q&A.
Thank you very much, Manon. And last but not least, we've got Imran, and then we will do questions and answers. Are you there, Imran? Or is he being chucked off? Yes, you're there.
I think you can all see my screen. Okay, perfect. So, yeah, so I mean, we all agreed earlier that GRADE works very well when there is evidence, but when there is lack of evidence, then obviously it cannot be used. It has got its challenges. And we face the same challenge within the European Association of Urology Guidelines Office when we are dealing with like rare diseases or when the evidence is not available. So one of the approach that we have taken is what we call the EAU recommendation approach. We have used some of the pillars or some of the principles of the GRADE, So what we do, we have created a form. And first of all, we summarize the evidence, whatever little evidence is available. For example, if it's coming from the case series or case report, we will just summarize it over here. And then the panel will judge based upon whatever information is being presented to them, whether it's a strong recommendation or based upon it, it could be a weak recommendation. And that's not the only thing the panel will look. Along with the evidence, they will also look at the ratio of benefit to harm. So if it's about an intervention, they will look if there are more benefit than harm. If there are more benefit than harm, then obviously they can make a strong recommendation based upon that. Then the third thing the panel looks are the patient values and preferences. And in some of the panels, we have got patient advocates as well. So they can share their views, they can raise their voice, and they can guide us in the right direction. What are their views and preferences? And are their views and preferences, are they consistent or are they variable? Are they known? Are they unknown? And based upon these, we classify the evidence as either strong or weak. And then obviously we look at the gaps in the literature, because that needs to be identified so that future research can be directed towards that. That's the first step that we take while writing these recommendations. Along with that, for each of the intervention, we look at the key outcomes as well. And again, we look at the ratio of the benefit and harm. For example, the outcome could be like overall survival or the other things as well. So those needs to be identified. They have to be listed, and then we'll explore them about the patient values and preferences like quality of life and all those things, and even the side effect of the medication. And based upon that, the panel can make a strong or a weak recommendation. So this is in a nutshell. I know I went very fast. It was a fast overview of the EAU process, but along with that, while making guideline recommendation, when there is no evidence available or when there is conflicting or even with low level evidence, we use Delphi process or sometimes modified Delphi process. This is one of the Delphi process we did on a prostate cancer. I know prostate cancer is not one of the rare diseases, it's one of the most common cancer, as the commonest cancer. But like there can be some unique questions in patient with prostate cancer as well. So sometimes we have to involve in Delphi process as well. But these are the two main approaches EAU has taken. One is the guidelines recommendation process, and second is the Delphi or the modified Delphi process. The third thing that we are now developing is the using real world evidence. So that's something we have invested a lot in the last 4 or 5 years. So these are the 2-3 approaches that we have taken to sort or to minimize the problem that we are currently facing.
Brilliant. Thank you very much. Tom, would you like to?
Thanks, Matt. So we continue to talk about the strength or the quality of the evidence. And one of the assessments that we've been doing in ERN Gentauris is to look at the available evidence and then consider how likely stronger evidence is to exist within a reasonable time frame. Again, it's a bit of a subjective judgment, but usually if you're chatting it through with the patients and the experts, they would reasonably say, hang on, you've got a set of case studies or a cohort study that covers 40 patients. It's really unlikely we will get a study of any description with more patients than that within the next 10 years. So what you've got to make the decisions you need to make today is relatively high quality evidence. And that's, we use that as going some way towards how strong a recommendation you can give for today. Because the other thing is guidelines get revised, they get reconsidered, they get recontextualized over time. So they're not fixed for the rest of time.
Thanks, Tom. I don't know whether Simon, I think you'll be on the panel next time, Simon. It's good.
Sorry, it's only my second question.
No, it's good.
Just in response to that, and sorry, I don't want to misquote you. I want to try and quote you and get it right. But but you talked about, are we likely in the near future to get a bigger study than we've got now? I paraphrase, but I hope that's roughly right. What I would say is I'm not always interested in big studies. I'm interested in good quality studies. So
yes, I didn't say big, I said better quality.
Oh, okay. In that case, we are in full agreement with each other. Thanks very much. Because I think it can be the case that we've got loads and loads of all this stuff, and we don't know what to make of it. And actually, a relatively small, good quality study may be doable in the relatively near future.
Yeah, although in rare diseases, we would often love to have a randomized, double-blind, controlled study. And in many conditions, they are just impossible either for pragmatic, moral, or ethical reasons.
Yeah, no, I agree with that. And actually, just to add, this is slightly off topic, but I think one of the real big problems is having poor quality evidence, because it almost then stops you doing a decent randomized controlled trial, because people have got their sort of views of, well, what might work, and I don't want to be randomized to placebo if there's sort of half a sniff that this treatment might work. I'm desperate to get that. So I think sometimes we or the research community does a disservice by doing poor quality studies.
So slightly off topic, but in response to if you have really good quality natural history data, then I think in rare diseases that justifies a single arm interventional study. If you have very poor natural history data, no matter what people believe, you won't get a good result from a single arm interventional study.
No, I think we're in complete agreement. Yeah, thanks.
Any other observations? I wasn't managing the chat. Nora, maybe you could, if there's any points or questions from people in the, you can raise your hand as well.
Yeah, there are some comments from Birgitta, for example. It is very good with guidelines in rare, common for many rare diseases like sleep problems, behavioral issues, since that is often topic shared among parents from different patient groups, and we always find we have a lot of in common, for example. And I think that's it.
Brigitte also made a really good point about how well known the disease mechanism is, which is a similar point to really good understanding of the natural history. And I agree that can really help.
Yeah, thank you so much.
Antonio.
Hello, Matt.
Hi.
Everybody. No, I just wanted to point out that for some time now, even for common diseases, the holy grail of the randomized double-blind 12 weeks clinical study has been shown to have its weaknesses. And it's not exactly that we are trying to reproduce a very perfect and complete and effective and almost infallible way of providing evidence or searching for evidence in science. So the fact that rare diseases don't comply with that possibility in many instances is probably not that bad, in the sense that we need to come up with other solutions, and some of them were already mentioned today, or all of them probably, namely the fact that we can do longitudinal data collection nowadays, and it was not easy in the past. We didn't have the proper diagnostic assurance that we were comparing apples to apples. Now we have much more resources to be sure that we are doing precise diagnosis. We can collect data even from anecdotal reports about treatments that were tried, and I was involved in a European project, Sovaldi, where we did that for reported treatments for genetic variants of rare diseases. So not only from diagnosis of a rare disease, but even from different genetic variants, how that would imply changes to treatment, and sometimes very important ones, and the fact that we are able nowadays to make those informations available online, and they are accessible at the time of diagnosis when we come from a genetic diagnosis, which is not always the case. It's something that we should explore, as well as the natural history collection, as well as trying to create a framework to not only collect PROMs, but to collect PROMs that have some medical grade significance that may be adapted and improved for alternative pathways for approval of treatments and things like that. So I'm not saying anything original, sorry, but I would just wanted to reinforce what I heard here.
Thank you, Antonio. Agnes, you wanted to add?
No, I just wanted to, of course, we can talk a lot about trial design and outcome measures that are relevant and address all these unique single individuals, because I think that's what we're talking about in rare disease, that it's really decision making on an individual level and even on a group level is sometimes doing a disservice, I think, to each of our patients. But I do think we need to really work on the guideline methodology, and also regarding the levels of evidence, there are different levels necessary for different types of procedures. So of course, for very expensive, non-reversible and very invasive treatments, we need more evidence than for other type of evidence. So I think it's also nice to distinguish that, of course, with gene therapies and RNA-based therapies, we really have to discuss also the type of intervention and not only any type of intervention.
Thank you. And any other, Rosina?
Roisin, yeah.
Roisin, oh, sorry.
Thanks very much. Yeah, a really fascinating conversation. I suppose I come from the HTA side of things. So I have a different way, we have a different perspective, I guess, on some of the evidence that we see, and perhaps to some of you maybe a little bit more black and white, but actually I don't believe it is. And I think this has been very interesting to see how different types of evidence, first of all, are elicited. And I was interested to hear, so you're trying to find it from systematic review, but of course that clinical opinion aspect, so primarily coming from Delphi mechanisms. But I was also interested to know, does anyone use the consensus elicitation, you know, so some of the framework coming out of Sheffield in terms of actually formally trying to synthesize clinical opinion, but also the uncertainty around that clinical opinion, which is something I think that's a little bit more difficult to capture and communicate, importantly, to decision makers, which in your case is the group that you're trying to get consensus from, I guess. But also the separation, and I think this was touched on earlier, the separation of the evidence that's available, which can sometimes be quite uncertain, to separating that to the decision that's made using it. And sometimes we do actually accept lower qualities of evidence in certain situations. And I think that's really important. So we shouldn't adapt as such the robustness of how we combine evidence or take evidence. We should maintain that, but you can actually make different decisions based on it, as long as we can adequately communicate what it's telling us, but also what it's not telling us. And then you make a decision based on that. So it's just something that struck me, that separation of, we have to be quite robust and clear and as objective as we possibly can in terms of the evidence piece. But then you can take other values into account when you're actually making a decision based on that evidence. But yeah, thanks.
Does anyone on the panel want to respond to Roisin? I can see, Velamine, you're looking for your unmute.
I was looking for that unmute button. No, thank you for your comments, and I agree with many things that I heard. And this is also for us, I think, as a guideline methodologist, a challenge, but also a task to take the role and present the evidence to the panel to really distinguish between what can it tell us and what can it not tell us, and not because it's low or very low graded, or because it's observational, omit it before you even looked at it. Because I also have worked with groups that then say, well, it's pointless, it's all very low. No, it's not. I think for some things you can really get some information out of that. And it's also a lot about how we present this summary. So yeah, I do agree on that.
May I
Thanks,
just
Philomene.
that
Yeah.
initial question? Apologies for coming back in. Has anyone used the Sheffield framework, the consensus solicitation? I don't know. No,
I have used it more as an academic exercise than in a real practical sense. I think it's working.
We'll have a look at it as soon as I'm off the webinar. I think Charlotte wanted to go next, and then Imran.
Yes, thank you. Thank you for the comments, and I'm very interested in the Sheffield framework too. I haven't seen it yet. But I just wanted to add that also in the GRADE methodology, this evidence to decision framework leaves some room for still providing a recommendation, even if the evidence is low. Although methodologically speaking, I think the reasons why you would still do a strong recommendation when there is low evidence is quite specific. Whereas I tend to have the working group do formulate a strong recommendation just because I want to provide the field with some concrete ideas on how to treat patients. But I think there is a lot of truth in that we have to base our decisions on something else other than the evidence. But still, we need to be very transparent about why we do it. So we try to be as objective as possible when it comes to the evidence, and then we can still formulate recommendations, even if the evidence is very low, as long as we are transparent about it.
Thanks, Charlotte. Just before we come to Imran, I made a note, how do we optimize the evidence which is available? And in rare diseases, quality of evidence can be very different. Low, what is seen outside is low evidence, actually can be very rich from the rare disease community's perspective, because actually the quality is better. Size doesn't equal quality. I think that's one of my messages from today. And the other bit was I picking up Philomena's point at the beginning, and then Tom and Manon, that looking at maybe a broader search of the available literature can bring a richer picture of evidence out there, which can inform that clinical discussion, evidence to decision making. And I think that bit in that GRADE process, I think, is where we sort of do an enhanced approach, really, and do the structure around optimizing the evidence more broadly, which includes evidence from real world evidence data, and from the clinicians as well. So I think that for me, I'm seeing how an enhanced GRADE approach actually can be articulated from today's discussion. So Imran, I just wanted to cover that before I forgot. Sorry.
No, I think it's important. No, it's important to summarize things, and you have done the right thing. So just wanted to briefly respond to what Roisin said. I think you were referring to the Delphi framework, right? The process of doing the Delphi prioritization process. So yes, within the EAU, we have done 2 or 3 prioritization exercise. Is one of my colleague who is more of an expert in this, but we have done that. We have adopted that, although we don't belong to an ERN, but we have done that.
Thanks, Imran. Any other comments from the chat, or people want to join in? We've got 4 minutes left of today's webinar. Everyone's, I think, So I have to, before I hand over to Nora, in England we have like terms for collectives, you know, so we have a Parliament of Crows, or you know, a Pride of Lions. I'm just wondering for methodologists, what would be the collective term? Maybe a grading of methodologists would be the right one. But I think today was really exciting, bringing together the methodologists from the different networks and from the EAU, and because I felt that we were all sort of not stumbling, but we were trying to get over these challenges in our own ways. And I think today's webinar has started a conversation together where we can collaborate. So I really appreciate everyone's contribution and the participants. But I hand over to Nora to close.
Thank you, Matt. Actually, echoing your words, I make some notes of you today. And first of all, I would like to congratulate the speakers for the fruitful discussion, and also the audience for their contributions and input. Hearing to you, it is clear to me that we are all in the same boat. Basically, we want strong guidelines that will support clinicians in their practice and ultimately benefit people living with a rare disease. There are methodologies. We particularly talked about GRADE today, and we are now in the process to enhance it and enhance this, as Matt highlighted, so that we can review systematically all available relevant data for rare diseases, published and not published, for its optimization. I believe that, as it happens in every evolution process, there are challenges. They have been discussed here today. However, it is in our hands to overcome this, taking as an example to this webinar. And I would like to highlight the importance of the European reference networks, the EURORDIS, to drive this shift of mindset. And I am truly happy to have listened to the beginning of an exploration into these questions here today, where also possible solutions and many ideas have been shared for inspiration to others. And it is my hope to see activities surrounding this topic in the EURORDIS and beyond in the upcoming months. Also, in another note, I would like to inform you that the outcome of today's webinar will be a collaborative position paper, and we will keep you updated about its publication. With that, let me close this webinar, and unless you have any comments, any of you.
Just a short reminder, it's important to get your feedback on webinars like this. So I've just put the survey in the chat again. Please complete it so we can learn from today. That's very much appreciated. And if some of you are really interested in the topic area and you'd like to get involved more in how we go forward with this, please drop me an email or mention it in the chat now, and we'll make sure we include you in the following work, which we'll look at. Thank you very much to everyone, all the panelists, for taking part, and thanks, Nora, for chairing.
No worries. Thank you.
Take care.
Thank you. Bye-bye.
Have a nice evening. Bye.
Bye, everyone.
Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Bye-bye.
Everyone.
Is everyone? I don't know how to do this. I don't know how to move people on. Anyway, I think people are quiet in the background. They're starting to go remove. I'm just trying to, if people can stay for a debrief. Remove. Last one. Oh. One more. So I think no. So I think that's everyone. Thank you very much. I think we've lost Iris. Sorry. No, we've got Iris.
Willemijn is has already
Willemijn. Dutch names. Oh, I'm glad I didn't have to say your last name, Charlotte. My
Sorry.
voice. I thank you so much for today's webinar. I thought it was brilliant. I think it was great to have that joint conversation.
Yeah, thank you for organizing, man.
Yes,
I
thank you
think
so
it's
much.
it's an area for us to continue to collaborate on, which I think would be really nice. I'll have to go back and listen to the webinar a bit to pick out some of the points, but that the focus in looking at evidence and what do we mean by evidence, I think just by opening that up, I think will really help us. But no, I thought it was a really nice format. I don't know your views or your thoughts.
Okay. I liked it a lot. I'm thinking, what did we not address? But I think most things were addressed, weren't they? Yeah.
I think one of the issues that we struggle with as well sometimes is, what is the definition of a guideline? Because we haven't touched upon that today, but sometimes I feel that we are writing like a textbook or a handbook as opposed to really a clinical guideline with recommendations. I believe that is maybe an issue to be discussed in a later stage as well.
It's interesting. I feel that we were so aligned on what we're doing and the methodology. I didn't see anybody disagree with the way we do it now. That made me quite happy that there was not a lot of this agreement on agree and grade. So I think that was really nice. But you feel that there was still doubts about what we're making or what our goal is, Charlotte?
No, this is just my experience from Ithaca and also rare guidelines in my other work. That sometimes I feel that there is a discussion on a definition. Yeah, but it's just some other issue that we haven't talked about today, but that I sometimes struggle with, and I'm just wondering if you feel this same issue as well.
So it's just a lack of awareness, right, on the methodology.
Maybe, yeah.
Lack of knowledge on it. So that's something we really have to do better also, and that's of course what we're doing also with webinars and to really tell people what we're doing and why.
Right.
Important.
I really felt I learned a lot, and I've been involved in some guidelines for a bit now, and I used to say with the patient representatives, when you get to the research bit, it goes quiet and people go in a darkened room and do the work. And actually with rare disease guidelines, that's not the case. That research stage actually is the most fundamental, that patient representatives should be involved. That point around finding that, finding what evidence is out there, some publications which might not be, picked up in the search, being part of the discussions around the emerging evidence, that discussion between evidence to decision making, to decisions. Actually, as a patient representative with rare diseases, your involvement in that is absolutely fundamental, because your preferences and views are on around weighing risks and harms and benefits together. And that really came across today, that actually when we talked about this, the discussion around the evidence is, if for rare diseases, is actually a bigger discussion which is had or needed, and bringing all that relevant evidence, wider evidence like real world data. I think Manon with Gentoris, I think it was the nice lady in Nijmegen. I think she's left. She did the registry. She had unpublished data which was all about actual risk of cancers from different tumor types, which was 10 years, and it was such a so you as the clinicians in the networks don't just come with their opinion. They actually have lots of other resources which maybe haven't been published yet. So I really thought that and focusing on that point of the research pathway or process, I think is really key. And I'll write up today. Hopefully you'll be okay with it, and you can give me comments and stuff, and I'll come up with what I think we've got consensus as well on some of the approaches which are being automatically taken. So I think just by setting that out, it will be really valuable. But it will be joint paper. So, you know, each of your networks will own it as well. I think that for me is the most important thing. It's not a EURORDIS thing. But no, I really appreciate today, and I, you know, there was lots of other nerds online, you know, methodology nerds. So it's
quite surprising, I must say.
we had 60 of them. I thought that was really good.
Oh, so funny. Yeah.
So,
Some patient representatives I saw, but and not many people I knew. Yeah.
No, it was great. So thank you again. I don't know, anything else from your side, Iris?
No, I think I was at some point looking at the audience to see what whether it were project managers but I think I recognized maybe 20% of the names, not too many, but there were some project managers, some patients. So I think it's really good that we also had a shared audience. We could even consider when writing the paper to also maybe liaise with some specific groups, being methodologists, project managers, patients, whoever groups we can think of, to make them read with us to see sort of pre-peer review stage, to see whether it's also covered from their side. I think the audience was really interesting. And I think the 5-minute presentation concept works well to keep people.
It was good.
Still, that helps for people to don't fall asleep and to not do other things. That really helps. Yeah, I could really see everybody paying attention for the ones who had their camera on. Because a lot of them had it off, but those paying attention, I think that works well. Yeah.
I was asked to do a 30-minute presentation. I looked at the people who asked me. I went, what? I get told 8 minutes max. But I must confess, I got emails from people internally, from my colleagues in EURORDIS, and they're saying, you're doing a webinar on Monday on methodology. And I was going, why are you asking me this? You know, it was coming from, and they had been approached. So it actually, the word got out, and we were getting people like from HTA, etc. So I thought that it was this topic area which people were interested in, and more outside the usual suspects, as it were. So
yeah, well done.
Brilliant. Manon, from you before we finish?
No, nothing to comment.
Thank
you for the initiative.
And thank you for persisting with the Dutch Wi-Fi, VLAN. Is it called Wi-Fi or is it called VLAN? Here it's VLAN.
Wi-Fi.
Wi-Fi.
But Wi-Fi, yeah.
Wi-Fi.
And the Dutch pronunciation.
And from you, Charlotte, before we finish?
No, nothing further to add. I think I thought it's very interesting also for me just to hear what the other issues are that arise and what your solutions are.
Brilliant. All right. Well, thank you very much. It was a nice start to the week. Wish you a good rest of the week.
Yeah.
Take care.
Thank you. Bye-bye.
Thank you.
care.
Bye.
Bye.